For our next session, we're going to take a closer look at environmental factors, occupational factors, and how they impact kidney health. And today we have several important guests who each have different perspectives from industry, from science, and from medicine to elaborate on this topic, which has captured the imagination of patients, medical professionals, and government officials around the world. Our next guest is Dr. Kathy Tuttle, and many of you who are watching know Kathy from her global reputation and her reputation here in the United States. Kathy is a professor at the University of Washington. She's very involved with the Kidney Research Institute at the University of Washington, and she's also a lead investigator on translational science. She has a very esteemed record at taking a look at the cardio-renal nexus. And this is something that every kidney patient is aware of, is that if you have a kidney problem, in many cases, chances are you have a heart problem. But the understanding of how these two systems work together and how they're influenced by other factors is an emerging area of interest, not just for patients, but also for industry and researchers. Dr. Tuttle, thank you so much for joining us. Why don't you go right ahead?
Well, thanks very much, Paul. Thank you to AAKP and George Washington University for inviting me to present at this year's 2024 Global Summit. Today we'll talk about transforming kidney care by accelerating translation of evidence to practice. Here are my disclosures. So I'd like to start with the problem we're trying to solve. And while we'll address chronic kidney disease in general, I'd like to start with the problem of diabetes, because it's the most common cause of chronic kidney disease worldwide. Currently, 537 million people living with diabetes, and this is projected to grow to 783 million by the year 2040. So realistically, for the rest of our lifetimes and for the foreseeable future, more and more people will be living on this planet with diabetes. And living with diabetes means living with diabetes complications. Even today, 4 in 10 persons with type 2 diabetes and 3 in 10 with type 1 will develop kidney disease attributed to diabetes, so-called diabetic kidney disease, making it responsible for half of all chronic kidney disease worldwide, by far and away the most common cause. And while our traditional focus in nephrology has been on progression to kidney failure, of course, a very important outcome, truthfully, that is a ragtag survivor band of just 10%. The reason is because of the extraordinary competing risk of death from other complications of chronic kidney disease, particularly heart failure and atherosclerotic cardiovascular disease, which are squarely related to having CKD. So now when we think about addressing chronic kidney disease, we need to think about the totality of risks, certainly maintaining kidney function, preventing kidney failure, but most importantly, saving lives and also reducing the cardiovascular complications that disable and harm so many people with chronic kidney disease. We now have a pillared approach to CKD and diabetes, again, the most common cause. We have the traditional renin-angiotensin system inhibitors in the form of an ACE inhibitor or an ARB, the SGLT2 inhibitors, a non-steroidal mineralocorticoid antagonist, finerenone, and most recently, the advent of the GLP-1 receptor agonist. With regard to how do we implement pillars of therapy, we have the KDIGO guidelines. Again, I'm drawing from the diabetes and CKD guideline, but it's important to recognize that the general CKD guideline is basically built off of the diabetes platform. 1, because diabetes is the most common cause, and 2, because what we've learned is that these therapies to date, the 4 pillars, appear to work across non-diabetes causes of CKD as well. So diabetes is the portal in, and from there, these therapies can be applied to many common forms of CKD. So of course, the foundation of optimal CKD care is a healthy lifestyle, but we also need medicines, and first-line drug therapies now include an SGLT2 inhibitor as well as a RAS blocker, but importantly, also statins to reduce the extraordinary cardiovascular risk, and in the diabetes population, often metformin for glycemic control. We need to recognize that risk factors, including glomerular filtration rate or eGFR, derived from the blood creatinine level, and urine albumin, need to be reassessed every 3 to 6 months. And that's because if they are not optimally managed, We will be adding what we call risk-based therapies, either in the form of a non-steroidal mineralocorticoid antagonist or a GLP-1 receptor agonist, and in some cases we'll add antiplatelet therapies for heart protection. And finally, all of this is done in the context of good control of conventional risk factors. So that would be blood pressure, lipids or cholesterol, and glycemic control in persons with diabetes. The evidence really comes from a number of clinical trials. We've truly been in a transformative time over the past 4 years. The first breakout trials were the SGLT2 inhibitor trials, and we really call them the trilogy. Every single one of these was stopped early based on clear evidence of benefit. This was a first ever in the field of kidney disease. We had stopped trials earlier for futility or safety, but until the SGLT2 inhibitor trials, never for overwhelming benefit. And it's not so important that you pay attention to all the details except the following. As we proceeded across the 3 trials, the populations extended from diabetes and credence to about 1/3 without diabetes and 2/3 with diabetes and DAPA CKD. And finally, in IMPA kidney, 51% of persons with CKD had no diabetes at all. We progressively lowered the limit of GFR to start these drugs from 30 to 20. And we also lowered the urine albumin criteria from 300 milligram per gram in credence to none in IMPA kidney. And what you can see across the board, the hazard ratio, it's a measure of relative risk reduction, is 30 to 40% across these different trials with broader and broader populations, which is how diabetes was the portal in, but the therapies extended now to most forms of chronic kidney disease, which is why they're first-line therapies for really all patients with chronic kidney disease, along with the traditional standard of care. However, even with these therapies, the red arrows indicate residual risk. So that's the risk that's left even after being on SGLT2 inhibitors, which is why, based on particular patient characteristics, we reassess albuminuria and GFR, and if they are not going in the right direction or achieving targets, then we will be adding additional therapies. What therapies might those be? Again, back to the KDIGO guideline. The first one I'll discuss is the non-steroidal mineralocorticoid antagonist, finerenone. This was actually studied in 2 pivotal trials, one with a cardiovascular outcome as the primary outcome, the other with a kidney disease outcome as the primary outcome, all performed in people with type 2 diabetes and CKD. And here you see the trial design reflecting the risks that I've told you about. They're not only kidney risks, but they're also cardiovascular risks. And this is what we call a pooled analysis of the 2 trials together. Bottom line was they enrolled over 13,000 patients and followed them for a median of 3 years. For the cardiovascular outcome, we saw a substantial reduction in risk. On the right side, you see something called a forest plot. The big win here was on reduced risk of heart failure. And across the board for the kidney outcomes, every single one was positive. And so these drugs are now recommended for people with diabetes and CKD to reduce both the cardiovascular risks, especially heart failure, as well as the risks of losing kidney function, developing kidney failure. And even though this trial was conducted before SGLT2 inhibitors were standard of care, there was still something called drop-in use. There were some people in the study whose doctors prescribed SGLT2 inhibitors. So while when we look at this data, we have to consider it exploratory or hypothesis generating, not definitive, we saw similar risk reduction for the SGLT2 inhibitor users, suggesting that the drugs act additively together to protect the heart and kidneys. The newest kid on the block is semaglutide. And semaglutide has come to us through the FLOW trial. It was the first kidney disease outcomes trial, and again, done in type 2 diabetes, as these trials normally are to begin with. It was a very typical population with CKD and type 2 diabetes. This trial, too, was stopped early for clear positive efficacy. In fact, on October 13th, 2023, the Data Safety Monitoring Board gave a recommendation to the steering committee that it would no longer be ethical to continue to randomize people to placebo because of the clear benefit of people receiving semaglutide. The hazard ratio, 0.76, this is a 24% risk reduction. And the reason for the check boxes is this. When we do a clinical trial, there's something called a hierarchical testing strategy. This is a very important aspect of the experimental rigor to really prove effects on these very important outcomes. So the primary outcome was a kidney disease outcome. But what the hierarchical testing does is it allows you to test additional outcomes to confirm the benefit if the one above it was positive. We had a positive effect on the kidney outcome. We had a positive effect on GFR slope. This is how fast kidney function is going down. We had a positive effect on the major cardiovascular outcomes, myocardial infarction, stroke, cardiovascular death. And then the ultimate endpoint of all, we had a benefit on all-cause mortality. Lives were saved by this treatment. Here's the composite kidney outcome, which was a combination of declining kidney function or kidney failure. You can see the clear positive result with a number needed to treat to prevent one outcome at 3 years of just 20. This is a very low number needed to treat, meaning very favorable kidney response. When we classify risks of kidney disease, we do it by both urine albumin and GFR. Both are required to adequately classify risk. And remember that in the FLOW trial, this was a very high-risk group of patients. However, what we see in real-world practice is that albuminuria and proteinuria testing are rarely done. Overall, in the CKD population, in this real-world study from Providence and UCLA Health Systems, only about 15% of people were tested annually. And in the highest risk groups, those who also had diabetes, prediabetes, hypertension, this was only done about 20% of the time. And this maps very closely to underuse of medications. So this study was conducted in the 2006 to 2017 timeframe, before the advent of the SGLT2 inhibitors, finerenone and semaglutide, when all we had were ACE inhibitors and ARBs. And you can see that over time, from 2006 to 2017, the bars show 3-year inclusive time periods, that there was progressive increase in use of these agents. But in total, in the last time period between 2014 and 2017, those with the most clear indication to receive an ACE or an ARB, meaning persons with diabetes, CKD, and hypertension, only 25% received these therapies, mapping back to the underdetection of albuminuria, which drives treatment decisions. At the same time, we were using more proton pump inhibitors and more nonsteroidal anti-inflammatory drugs. In fact, in total, persons with CKD were getting these medicines 33% of the time. So we were more likely to give toxic drugs for the kidneys and less likely to give protective drugs. So no wonder the outcomes for patients have been suboptimal. This harkens back to the lack of CKD awareness. This is true for both healthcare professionals and patients. Looking at patients, 80 to 93% with CKD are unaware they have it, making only 7 to 20% aware. And when we look under the hood, then this leads to suboptimal monitoring, such as proteinuria monitoring. Most people are not at adequate blood pressure or blood glucose control if they have diabetes. And while the RAS inhibitor use may look improved compared to the earlier time frame, so this is 2019-2020 as opposed to 2006 to 17. So here you see RAS utilization up to 70%. If we look a little deeper under the hood at the origin of these data, which is our Cure CKD registry, again from Providence and UCLA Health, we looked at not only did a person receive a prescription, but whether after 90 days they were still receiving it. So what you can see is that at a single point in time, yes, we could say some 70% had received an ACE or ARB prescription, but after just 90 days, this dropped off to 40%. And that's because medicines are often stopped for a variety of reasons, but there's been lack of attention to restarting. And patients only benefit from treatments they receive. So even through 2020, we see overall underutilization. By this time, the SGLT2 inhibitors and GLP-1 receptor agonists were entering the picture for various indications, especially for treatment of diabetes and cardiovascular disease. But you see the use is very low, and most people with CKD either have cardiovascular disease or diabetes, but we're looking at use rates of 6 to 7%. And although the numbers are small, you see the same trend that after 90 days, the only direction is down. It's not up in terms of persistent use of these medicines. Our study's been corroborated by other large databases. This is from Linda Freed and colleagues looking at a large US insurance claims database. And if you focus on medication utilization, you see very similar results. ACE-ARB use low, and there are more discontinuations than initiations, and the same across the board for the MRA class, which is related to finerenone, for SGLT2s, for GLP-1s. So now one of the biggest challenges is implementation and maintenance of effective therapies so patients have a chance to benefit from treatment. When we think about high-risk groups of patients and who we should be targeting, I'm going to walk back to diabetes again because this is where we have the clearest indications for screening and detection and where we know people have an underlying condition that puts them at very high risk. This again is from the Cure CKD registry, over 650,000 people between 2015 and 2020 with diabetes and no CKD. And we followed over 5 years and at least by demographics tried to better understand which groups were more likely to develop CKD, new onset CKD. Why is this important? Because there's so much we can do about it. And the earlier we detect a disease in the course, the more effective those pillars of therapy are likely to be. So first, on the right panel, you see demography by race and ethnicity, and compared to the white reference group, all non-white groups except Asians had substantially higher risks than the white population. Highest risk actually seen in people who identify as Native Hawaiian or Pacific Islander, 60% higher risk. Black or African Americans and American Indian or Alaska Natives, 30 to 40% higher risk, and those who identify as Hispanic or Latinx, 25% higher risk. So clearly these race and ethnic groups are very important for targeted screening efforts. On the left, I'm showing you again time trends over the 15 to 20 time period, 2-year inclusive time periods. We do see some trend downwards, but what does the red line mean? That is an incidence rate of about 7% per year. So do the math. Over just 5 years, that would accumulate to 35%. Exactly what we've seen before is whether it's type 1 or type 2 diabetes, CKD occurs in 30 to 40%. And if you look particularly at who's above the red line over all time periods, it's persons over the age of 60. So we add older adults to people who should be targeted for screening. Also, it's in both men and women. And this is important because women have been less likely to receive 4 pillars of therapy than men, yet they're equally likely to have the disease. So there are many barriers to underutilization of therapy. They may be patient-related. There have been issues, particularly with some populations regarding trust in the healthcare system for very legitimate reasons, and we do need to focus on rebuilding trust. Clinicians are burned out. They're very busy. They have 15-minute visits with very complicated and sick patients and multiple issues to address. It also depends on where people live. Even in a high-income country such as the US, where drug prices are very high and these medicines are not always covered by insurance, the drugs are out of reach for many people. And this is even amplified in low and middle income countries where there's even further disparities in access to medicines. Health systems have been lacking in guidelines and support to implement proper care of CKD. And finally, health policy across regions of the world, high, low, and middle income countries have not prioritized CKD or had CKD policies that would drive insurance coverage and systems of care to support CKD detection and intervention. And then again, the drug prices are really an issue because even in the US where drug prices tend to be high, it doesn't mean that lower drug prices elsewhere make drugs very accessible either. So here are prices as of 2 years ago. These really have not changed. This is the retail price of SGLT2 inhibitors and GLP-1 receptor agonists for just a 30-day supply, paying retail price at a pharmacy. The US is higher than the rest of the world. But even if we look at some lower income countries, for example, India, where the price looks much lower, where the per capita income is lower, this price, even though it looks relatively low compared to the US, could be out of reach for many people. So this is not just a US problem, it's a worldwide problem. So it not only is determined by the price per se, but also what the relative income levels are that allow people to afford and access medications. So back to the holistic approach, and this guideline for diabetes has now been adopted to non-diabetic persons with CKD, at least on first-line therapies. The second-line therapies of risk-based treatments involving a non-steroidal mineralocorticoid antagonist, finerenone, or GLP-1 receptor agonist, semaglutide, are reserved for people who need additional therapies, for example, to lower albuminuria, glycemia, or weight. But these are highly effective therapies. And the last two classes are now also being studied in persons with CKD and without diabetes. So stay tuned. We may very well see a shift to a higher priority of these agents, particularly if they're proven to work across non-diabetes patients as well. This is going to be complicated. It involves many, many patients. Our healthcare systems and health policies have not been prepared for the onslaught of CKD. And now it really matters because there's so much we can do about it. But we've really, from a KDIGO perspective, envisioned team care as the way to get the job done. There are many players on the team, all of whom can fill important roles, whether it's in diagnosis and prescribing, education, medication management, for example, by pharmacists, nurses who also assist with education and patient management, advanced practitioners who can also play very important roles. And then we also want to remember the importance of healthy lifestyle, including dietitians, physical therapists, exercise specialists, especially in promoting healthy lifestyle. And this comes along with paying attention to other important body parts that are linked to CKD, good oral health, good foot health, good eye health, and then, of course, good mental health. And together, we can get to the goal of improving overall holistic management of diabetes and CKD. So the take-home points are that SGLT2 inhibitors and an ACE inhibitor or an ARB are first-line guideline-directed medical therapies for persons with or without diabetes and CKD. Currently, GLP-1 receptor agonists, particularly semaglutide, and a non-steroidal mineralocorticoid antagonist, particularly finerenone, are considered risk-based guideline-based medical therapies for albuminuria, glycemia, weight, and CVD. As the trials extend to the non-diabetes population and more data accumulate, we may expect the recommendations for these classes of agents to elevate. However, the lack of CKD awareness, detection, and access to care are barriers to receiving guideline-directed medical therapy, and multidisciplinary team care may be a way forward to improve guideline-directed medical therapy implementation for the many people who could benefit. So the theme of World Kidney Day in 2024 was Kidney Health for All, advancing equitable access to care and optimal medication management. There was a major editorial written and published in Kidney International. And so this year, this is the major theme for World Kidney Day, which I thought would be appropriate to celebrate with you here for the Global Kidney Disease Conference. Thank you very much.
Dr. Tuttle, in so many different ways, you're seen as a pioneer by patients and by medical experts in areas that are often overlooked, and especially in the areas of historically underserved communities and those who have not had the opportunity to benefit from science and innovation. And I was wondering how your personal experiences and your insights on that have driven your interest in creating more substantive patient engagement and involving more people who are impacted by disease in science and research.
Well, across my career, it has been eminently clear to me that people with kidney disease suffer a disparity by disease state. It's intersects with other disparities, say according to race and ethnicity, sex and gender and age. But within our healthcare systems, kidney care is not prioritized despite its importance. CKD will be the fifth leading cause of death over the next 20 years. And yet, compared to other leading causes of death, it's hardly prioritized. And I have felt that it was so important to elevate this voice, to have our patients be heard, and to hear their concerns really at a policy level so that priorities can change. And we value lives of people with kidney disease like we do for other really important health conditions.
Dr. Tuttle, given your wide perspective and looking beyond the state of Washington and beyond the United States, can you tell me what's the sense of what's going on with international researchers and scientists? Are they embracing some of the lessons that you've applied on patient engagement and trying to bring more patients into science and research and clinical trials?
Absolutely. I work with people across the globe on these major trials, and virtually at every meeting, we have patients involved, and have really moved to patient involvement even from the very beginning of study planning, across conduct of the study, analyses, and reporting. And first off, the science is better and the reporting is better because of those voices, and they're international voices. The really interesting thing to me is no matter where we're from, the stories are so similar. Low rates of awareness, detection, late intervention, and horrible outcomes. And the patients from around the world are really committed to making life better for people. And, to be honest with you, we're just much more alike than different. And, even in countries where there's universal health care, they're still having this very similar problems with access because governments are saying we're spending too much money in those medicines. So they're limiting access. So to be honest with you, I think that having the patient involvement across all of these efforts has been critical. But what we've found out is that we're all struggling with the same things. And if we come up with ideas from one region or another to make things better, these are lessons learned that we can apply across lots of different scenarios. And so I think the patient voice has been a big part of what's catapulted the science forward.
Dr. Tuttle, one last question for you. The theme of our global summit this year is Vox Populi, the voice of the patients. And I want you to look into your crystal ball and tell me in terms of emerging therapies and emerging prevention strategies for heart and kidney diseases. Are you confident that we'll see more solutions coming in this decade? And what is the role of patients in their voice in terms of driving the science and driving innovations?
Great question. As I started my presentation, I showed you the four pillars of therapy: an ACE or an ARB, SGLT2 inhibitor, GLP-1 receptor agonist, and some inhibitor of aldosterone. And the reason I say it that way is there are newer versions of aldosterone inhibition in the pipeline that I think will probably be more effective than blocking the receptor. That said, if we got those pillars implemented in at-risk patients, so this would include people with diabetes, people with hypertension, people with a family history of chronic kidney disease or cardiovascular disease, we would dramatically, just with those therapies alone, reduce rates of CKD onset to begin with, primary prevention, and among those who develop CKD, many fewer people losing their lives or having major heart or kidney complications. So number one, before we, even ahead of new therapies, what we need is intensive efforts on implementing what we have. People are doing actuarial projections on this, and I'm not prepared to talk about numbers, but it would be a substantial reduction. So what we're really conceptualizing for additional therapies, so blocking endothelin, activating soluble guanylyl cyclase. I've been very interested in the inflammation field, treating residual inflammation with various targets that either block signals that promote inflammation or block inflammatory mediators. And finally, cell therapies. Where are these going to go? I think these are going to be rescue therapies, because I think the 4 pillars will take care of the majority of forms of CKD. And then what we'll have are people with what we call rare subtypes of common diseases, so-called endotypes. And then we'll have people with rare diseases where there's a primary inciting factor, such as an immunologic injury, who will need something else, whether it's to shut down the immunologic injury, like an IgA nephropathy, block IgA production, block activation of complement. They're still going to need the 4 pillars, though, to prevent progression. And then among people with diabetes, for example, there may be a residual risk. Probably it'll be a rare patient who has evidence of losing kidney function despite the 4 pillars. Then we're going to be looking at more of a precision medicine strategy based on biomarkers, imaging, maybe even kidney biopsies, to identify whether or not they need something else and what it might be. So I think nephrology of the future is going to look a lot more like clinical oncology, where we will phenotype people much more precisely, and they'll go down different protocol pathways for treatment. But I do think the standard of care will be the 4 pillars, and then additional therapies depending on risk and inciting factors.
Thank you very much, Dr. Tuttle, and I'd like to thank all of our speakers for this session. You've certainly given us a lot to think about, and just as importantly, you've helped challenge status quo thinking about the cardio-renal connection, outside factors that influence in the environment and in occupations, and you've created a sense of hope for patients on how they can impact change and innovation in research and science, be part of the process, and most importantly, to receive the benefits and the rewards when innovations come into the marketplace that address these issues. Thanks again for bold thinking and being creative and being part of this year's Global Summit.